difference between stridor and wheeze?
Sir, stridor actually stays the same voice in any position of the patient. It would be the same.
Okay.
Wheeze will be polymorphic.
It's a fixed sound.
Fixed
Other
sound.
one is a polyphonic.
Polyphonic.
Why ER physician should know about this? What is the importance of this?
By mistake, we should not treat stridor as wheeze nebulization.
Should not nebulize, because nebulization will not help in stridor. Stridor is due to a fixed hard obstruction. Other one is variable obstruction. It can be relieved by nebulization. Okay.
So breathing, we are talking. Respiratory rate was 28 per minute and saturation was 88% at room air, sir. Air entry, bilateral it was equal with chest having minimal scattered creps and bilateral wheeze present, sir. The chest exertion was
In a COPD patient, saturation 88, are you satisfied or you want to?
Yes, we have to keep a target of 88 to 92% of room air, sir.
Okay, why it is like that?
Because the hypoxia is the drive for the respiration in a COPD patient and we don't want to cut it off by giving 100%.
Okay, okay.
As he's having hypercapnia.
So what are the complications of giving oxygen in a COPD patient? So you give high load of oxygen, like given asthma or ARDS. What are the complications of high flow oxygen in COPD?
Rupture of bulla.
Rupture of bulla. High flow means high flow, not pressure. Central respiratory drive can abolish and can produce arrest. Okay, then other than that,
CO2 retention can increase.
Most important is that.
Okay.
But the other problem comes mainly in ICUs. Continuously putting the patient on oxygen or putting the patient on high flow oxygen with BiPAP or patient on ventilation, mechanical ventilation. What problem you anticipate in them? Dryness is not a big problem that any patient can have, no? But that will produce dependence. So once you put the patient on BiPAP or CPAP or ventilation or high flow oxygen continuously, then this patient will become highly dependent on your therapy. Then you will not be able to wean off the patient. So that also you should keep in mind. Okay. So first thing is it can reduce the respiratory drive. That may cause sometimes respiratory arrest. Second thing is if you do like that, afterwards it will become a problem in your ICU.
Yes. There was a pursed lip breathing, sir, on inspection, and there was minimum usage of accessory muscles.
What is pursed lip breathing? What is that? Why
that is to increase the
either
expiratory
patient
time.
will do it without any training, or we have to train the patient who is having COPD. So
that we can increase the expiratory time of the breathing.
So you are trying to put a PEEP, positive end expiratory pressure, so that air will stay more time in the respiratory tract and it will not run off from the airway. Okay.
Circulatory examination. Heart rate is 101 beats per minute. Blood pressure is 120 by 80, sir. All peripheral pulses were felt equally and bilaterally palpable. At this point, we put a weakness access was obtained, sir. Disability GCS.
What will be the peripheries in a COPD patients?
Peripheries will be warm.
Warm. Due to? So basics. Due to? Carbon dioxide.
Yes.
Carbon dioxide produces peripheral vasodilation.
Yes.
So that produces warm peripheries. Okay.
GCS, sir, patient was E4, V5, M6, pupil bilaterally 2.5 mm and pupil is reactive to
E4?
E4, V5, M6.
Okay.
Completely. And exposure wise, the temperature was 100.1 degree Fahrenheit, sir. And for which we had given injection PCM 1 gram stat at this point, and GRBS was 105 milligram per deciliter, sir. So, adjuvants of primary survey. ABG showed compensated respiratory acidosis with metabolic alkalosis. pH was 7.406 with the PCO2 of 56.5 and bicarbonate of 34.5, sir.
Why he has gone to metabolic alkalosis? What may be the cause?
Compensating the respiratory acid.
Compensation of respiratory acidosis will never produce metabolic alkalosis. Here pH is 7.4. So what do you think? Compensation means what? it is only compensation within the limits. So you should understand that basic thing is when you have a compensation for respiratory acidosis, pH will never cross more than 3 point. Normal range is 3.5 to 4.5. So it may be in between that range. It will go to the middle part. That means 7.35 to 7.45 means 7.4. If it goes to the opposite side of the spectrum, then it is becoming an alkalosis. It's a real alkalosis. Whether it is respiratory alkalosis or another metabolic alkalosis, we don't know. But it is not a compensation. Our compensation will not occur in a real compensation. So our compensation means when the pH go to the opposite side, it's a mixed acid-base disorder. So here there is a strong possibility of another alkalosis, possibly metabolic alkalosis. What can produce metabolic alkalosis in this patient? What all possibilities?
Hypokalemia.
Hypokalemia is the most important cause for metabolic alkalosis in a COPD patient. What is the potassium here?
So potassium was 4.2.
That is during ABG or after
ABG during an initial.
The first one itself. So we have to find for any other alkalosis, or you have to see the real lab value for even diuretic also produces hypokalemic alkalosis. So you have to find reason for alkalosis. Okay. So what basic understanding is the compensation will never put the pH to the opposite side. If it is going to the opposite side, it is always some other problem is existing. That we have to find out. Okay.
So ECG shows sinus tachycardia at the rate of heart rate of 102, sir. And there are T inversions of AVL first lead and V1 to V6. These
All
are
leads
old.
will have TIVA inversion. Okay.
Yes. These are the old changes.
Existing changes.
And ultrasound bedside, we seen that bilateral lung sliding was present.
Okay. That means?
So that means to rule out there is no
pneumothorax. Okay.
Then we reassess the primary survey and everything is stable. So going for the secondary survey.
Okay.
Second, 62-year-old male, resident of Kollam, not working at present. Known case of CAD in 2015, sir. He presented with complaints of fever, which was subjectively felt, and it was 2 days of onset, associated with cough with sputum production, and he is relieved it by taking paracetamol, which was prescribed in local hospital, sir. And association was there with shortness of breath since last 1 day, sir, which was acute onset, progressive it was, and interfering his activity, sir. So MMRC grade 2 is the scale sign, sir.
Okay.
And also he had complaints of vomiting and loose motion for 1 day, sir, which are watery in nature.
Okay.
Sir, for head-to-toe examination, sir, there are no pylorictus lymphadenopathy or edema, sir. And in upper respiratory tract examination, no sinus or no tenderness, sir. In respiratory examination, inspection-wise, barrel-shaped chest was seen, sir. And there is no supraclavicular hollowing. And minimal usage of the intercostal muscles and no crowding of the ribs, sir.
Okay.
And palpation wise inspiratory findings were confirmed, and auscultation bilaterally V's was present. In serious examination, S1, S2 was heard, and no findings of any corporal features like lower limb edema or tender hepatomegaly or raised JVP were seen, sir. And that is there. And after that, we had taken an X-ray for the patient, sir.
Okay. What is there in X-ray?
So, hyperlucent X-ray with tubular heart and diaphragm was pushed down, sir, with wide horizontal rib space and no opacities. That was X-ray.
So how do you manage this case in emergency room? That is the first question. How do you investigate?
So investigations we take ABG for
ABG is already taken. Then
and we monitor
X-ray is taken.
Oxygen saturation.
Saturation is 88%. Okay. Then controlled oxygen therapy is a treatment.
Yes,
okay. So you have to control the oxygen therapy because you don't want to over oxygenate the patient. Okay. Then.
So then we start with nebulizer.
What nebulization?
With salbutamol plus ipratropium bromide, we give nebulization.
How do you give salbutamol nebulization in a patient who is having breathing difficulty?
So with the nebulization?
How do you give? How do you dilute? How frequently you give? What are the side effects?
So 2 ml of salbutamol is given in 3 ml of NS and nebulized.
How frequently you give? Every 15 minutes. What are the adverse effects?
Adverse effects are tremors, tachycardia, and even palpitation and fatigue.
Then
muscle cramps.
Muscle cramps due to hypokalemia. Okay. What type of hypokalemia they develop?
Shift hypokalemia.
Okay. Then, other than salbutamol?
Ipratropium bromide.
Okay. What is the action of this drug? Anticholinergic effect. Okay. Then?
So after that we start with an antibiotics.
Antibiotic
coverage we need to give. Generally, like empirically, we start with levofloxacin or mifofloxacin.
Why levofloxacin and moxifloxacin?
Because they have both gram-positive and gram-negative coverage.
What organism you are suspecting in COPD?
Staph.
H influenza and staph? No. You don't suspect staph. H influenza, moraxella and streptococcus. These are the three. Streptococcus is gram-positive. H influenza, moraxella is gram-negative. You can suspect so many bacteria. Suppose somebody is coming from a hospital, another hospital, you can suspect hospital-acquired infection. But a community-acquired infection in a COPD patient, minimum things you have to suspect: 1 gram-positive cocci like streptococcus. Second thing is gram-negative like H influenza and moraxella. But this patient is already having diarrhea. How do you account that? What are the differential diagnosis?
For that we consider the atypical pneumonia.
One is atypical pneumonia. Other one, common thing?
Gastroenteritis.
Viral fever. Gastroenteritis. Any virus which affects the GI tract can aggravate the problem in a COPD patient. Okay. So diarrhea is one condition which can produce ABG. What problem it can produce?
Metabolic
alkalosis. If he is having severe diarrhea, you have to check whether the patient has developed alkalosis due to that diarrhea itself. Okay, so that is a different issue. We will not discuss that now. So diarrhea is there. So viral infections are possible. Atypical infections are possible. Okay, what atypical pneumonias can present all these features? How do atypical pneumonia present?
Organisms as Legionella, Mycoplasma,
Legionella, chlamydia. That which one will produce diarrhea? Legionella is most important thing. Okay. They are present in which circumstances?
In the AC ducts.
Okay. Those who are working in a closed environment, those who are working in an old AC, this one. So they can have diarrhea, they can have pneumonia also. But X-ray is normal, no?
Yes, sir.
How do you account that? What type of pneumonias these patients can have? They have interstitial pneumonia. Most of the time X-rays are normal. If at all you are seeing bilateral infiltrates are seen, this patient has got bilateral minute infiltrates. Okay, so that is possible, but generally speaking, this type of patients mostly they are viral infections. Viral diarrhea that has aggravated the problem in this patient: dehydration, alkalosis, and already patient is having COPD. That any time it can aggravate due to any other infection. So that is the most common thing, but our atypical pneumonia has to be considered. How do you diagnose atypical pneumonia? How do you diagnose?
Normally, it will be off with the normal pneumonia picture. The patient will not have pneumonia picture. That is a problem. So they have atypical features. What is a typical pneumonia feature? Typical pneumonia means what? Fever, cough, breathing difficulty, sputum contains large amount of blood. But atypical pneumonia means? EA involvement, hyponatremia, hemolytic anemia, altered behavior. These are the things. Okay. So we can only suspect atypical pneumonia, but this patient is already having COPD. He can very well have a respiratory viral infection that itself can produce sometimes diarrhea. Okay. Whatever it is, we are given nebulizations, we are given antibiotic coverage. You want to give moxifloxacin or levofloxacin. That even covers a typical organism. Okay, what else? Should we admit this patient in ward or ICU?
That
Admission is
Curve
fine.
65 is
So
depending
what is the
on
score here? Curve 65 scoring is very important. Age more than 65,
65.
respiratory rate, all these things you have to calculate and tell me whether this patient will go to ICU or what.
Sir, outpatient. Sir, ward patient, sir.
So this patient can be admitted in ward according to your criteria. Okay. So
Yes, sir.
this patient can be admitted to ward, but oxygen therapy should be given only to maintain the saturation between 88 and 92. That is more than enough. Okay. What else? How do you manage this case afterwards?
Sir,
So you have admitted the patient, you have given nebulization.
we need to regularly monitor the ABG and
For what?
for if the pH falls below 7.3 for respiratory rate more than 25, we need to plan of putting him on NIV. After putting him on NIV, we again, after 1 hour duration of the NIV, we check for hardcore scoring to see he is responding to NIV or not.
Okay. Failure or not.
Failure or not.
Okay. Then
that will guide us for the respiratory to maintain the saturation.
Okay. This patient has improved with your simple oxygen and nebulization. So no need to go for NIV.
Yes.
So what else you can do for this patient? Other than this nebulization and oxygen, what all things has to be done? Diet is last one. Before that.
IV antibiotics, then control of the diarrhea to give IV
Fluids
should be given because of it. Patient is having continuous loose stools. Then
what IV fluid do you want to give?
give
Plasma light. What is plasma light?
Balance.
What it contains? Which is the most important electrolyte which is not there in other IV fluids, which is there in plasmalite?
Magnesium.
So you have to be very careful when you are giving plasmalite. If the patient is having renal failure, you should not try to use it. Otherwise, any case you can give plasmalite. That is the most physiological solution. Or you can go for ringer lactate, or you can go for normal saline. Okay. Now, all these things can be given. So diarrhea means you have to give fluids. Then what else? Where will you use magnesium sulfate in COPD? What is the dose? Is it helpful? Is it not helpful? Is there any study which tells you that this can be given?
Magnesium sulfate is generally given as a treatment modality for bronchial asthma, but it has been tried in COPD in case of wheeze, where there's no detrimental effect, so it can just be tried, but there's no studies that backs up that it's very beneficial either.
So there is no studies telling that acutely it will benefit. Okay, it is a bronchodilator, but acutely it is not going to benefit. But it has shown that it has prevented the further admissions in a COPD patient. Okay. Repeated hospital admissions are prevented by magnesium sulfate infusion. But acutely it will not give any benefit. But action of magnesium in the bronchiole is it produces bronchodilation. Okay, so magnesium may or may not be given. It's an add-on drug. Steroids?
Steroids, they have a long duration. It takes longer duration to act, but it will be beneficial in the further progression.
Okay. Any inflammatory condition, including asthma and COPD, it is beneficial. But asthma it is more beneficial than COPD. But still, we give steroids. Then comes diet. What is the diet you advise to this patient? What diet you advise? What will you give for this patient? This patient is in your ICU. What diet you will give? What are the complications of that diet?
Low carb, high protein.
Low carbohydrate, high protein diet we have to advise for this patient.
Okay.
But what is the problem in this patient?
Diarrhea.
Diarrhea is already there. So we have to be very careful. Low carbohydrate is the ideal diet for COPD patients. High protein is also should be given. But only problem is this patient is having diarrhea that can sometimes aggravate by high protein diet. Why we give low carbohydrate diet? Carbon dioxide is
Less fat.
why? How?
It produces CO2, which again adds on to the
So carbohydrate metabolism end product is
Carbon CO2.
So you don't want that. So we don't prefer to give high carbohydrate diet. You give a normal diet. High protein diet is best because these muscles require protein. But unfortunately, this patient is having diarrhea. We had to wait for that. The diarrhea should come down. Okay. Other electrolytes, which are the most important electrolytes? Sodium is not that important because this patient is having atypical pneumonia. It can be there. Hyponatremia may be there. It was there, I think.
Hyponatremia
Was there? What is the sodium?
119.
How do you correct that? This patient is having 119 sodium. You think that atypical pneumonia. What may be the cause for hyponatremia? If you are thinking atypical pneumonia is the cause for hyponatremia, what is the cause for hyponatremia here? The reason for pathology for hyponatremia you should understand. The etiological feature is the pneumonia. And how can the patient develop hyponatremia? Diarrhea is different issue. I am talking about a typical pneumonia, regional pneumonia, how it produces hyponatremia. One is diarrhea. Okay, diarrhea is definitely there. Other than that, it can even produce SIADH.
Yes.
So you have to see that already diarrhea is there that can produce SIADH is urinary loss of sodium. So what investigation you do?
We do urine osmolarity,
Urine sodium. So these are the basic things. Immediately after seeing any electrolyte imbalance, check the urine for that electrolyte. You have to see whether that electrolyte is going through the kidney or not. So you are seeing hyponatremia, see the urine sodium. If it is more than 20 milliequivalents, then it is urinary loss. Same like that potassium. Hypokalemia is there, see the urine potassium. Okay. So that has to be checked. Okay. Whatever it is, hyponatremia is there. How do you treat this patient?
We start with 3%.
You start 3%. You start?
Patient because of the GI loss occurred hyponatremia, but
what do you
patient
start?
was also stable. There was no altered sensorium. Patient was fully conscious.
What do you want to start?
We can added salts we can give even.
Normal.
SIADH and water restriction.
You have not done the urinary sodium. This patient require only normal saline, fully stable patient. He is having diarrhea. You should know that there is a loss through the stools. We have not tested the urine salt to start at 12 of 10. So you give normal saline. That is more than enough. Finger lactate, normal saline, or plasmalate. Anything contains sodium. Okay, so that should be given first. Okay. Then you investigate urinary salt loss. Then if it is high, then you can think about tolvaptan afterwards. So this patient may require only normal saline to correct the sodium deficiency. If not getting corrected, altered behavior, seizure, then only you should think about 3% saline. Okay. Then sodium should be corrected.
Sodium should be corrected.
Next is what?
We need
Next we have to discharge the patient, no? How do you discharge?
After 2 days again, we see that if the is responding to the antibiotic or...
How do you know that the patient is responding to your therapy?
Patient symptomatically improving without any breathing difficulty or any GI loss, and I will be checking upon the lab counts, including the total blood counts and CRP also, where how the total inflammatory parameters are increasing or decreasing.
Okay.
And following it will maintain it.
Okay, so you check the inflammatory parameters and see whether the patient is improving or not. Then you have to discharge the patient. How do you discharge? What medication you advise for the patient? Inhalers. So you have to advise inhaler. What inhaler you advise? Which one? Formoterol and budesonide. That is the best drug. Formoterol is one of the best drugs can be used for COPD. Why it is like that?
It has acute action as well as it is a
Preventive action. So preventive action and a rescue action is there. So you can give formoterol with budesonide with dietary or ipatopromide. That is very important. Okay, so you can discharge the patient. What else is required for the patient afterwards? One more important thing is there. Two more important things are there.
So, if he is a smoker, has to smoke.
That he has to stop it. Then, breathing exercise, physiotherapy, lung physiotherapy. So breathing exercise is very important. Then, azithromycin prophylaxis, 250 milligram alternate days for 3 months. Okay, that also can be. Vaccination is most important. All these patients should be given vaccination. Which vaccination?
Pneumococcal.
And H influenza. Pneumococcal. H1N1 is optional. Yearly you have to take. Pneumococcal every 5 years. H influenza is every year. So that vaccination has to be given. Like we told, you have to advise the patient for breathing exercise. Then long-term oxygen therapy. What is that? LTOT.
To prevent cord pulmonale, we can advise
Baseline.
LTOT for the patient.
Okay, how much you give?
16 hours of LTOT, 2 liters.
2 liters,
2 liters
of oxygen
for minimum
16 hours.
That can prevent.
Worsening of the. It will prevent the cord pulmonale features.
How do it prevent?
It will desaturate.
Pulmonary vasodilation. So it prevents-
Vasodilatation.
so
Prevent vasodilatation. Vascular endothelial damage can be prevented by long-term oxygen therapy. That prevents, ultimately it prevents pulmonary hypertension and cord pulmonale. Okay. How do you treat pulmonary hypertension in a COPD and primary pulmonary hypertension? You know that or you don't? That is not available everywhere. Sildenafil. What is that?
It's PDA inhibitor.
So primary pulmonary hypertension, all these drugs can be beneficial. Secondary pulmonary hypertension like your COPD, these drugs are not effective. Okay, anything else you want to add? Want to add anything? Nothing. Okay, thank you.